it's going to be so easy. Tomorrow, little less. Not because it's hard, it's just because it's completely approach. You will see that we are going to start to work with computers, not with mechanics. It's analogy. Before we work with mechanics, now we want to start with the computers. It's completely different approach. Everything is going to be about neurology. We don't use energies, we don't use vibrations, we don't use feelings. It's only neurology. Every people, we have a completely different hard time or different time to understand depending on your background. You have more background in neurology, it's going to be easier. If you don't have background, you need to study more. Okay, what is PDTR? PDTR in neurology, but is that we are going to focus on something special. Reflexes. It's a reflexogenic system because 97 or 98% of our response, neurology response, comes from reflexes. We're going to understand later what kind of reflex we have. We have a primitive reflexes, we have a mature reflex, we have a different kind of reflexes, but all of them are automatic. Most of our posture, most of our response, most of our behavior come from reflexes. Then, for reflexes, we need to take care now mostly about the afferentation. It means the information. Computers need information. Then the computer processes information, understand information, compare it from the previous experience, and then we have a response. The brain is exactly the same. Today, the first modules is just about afferentation. What is the information we get, what information we process in our brain. The information comes from many different receptors. We have receptors for receptors, we have mechanoreceptors, like a Golgi, we have spindles, we have a visual, auditory information, taste, olfactory. We have a lot of different sources of information. All of them use more or less the same rules. Some of them have a small difference, but in general, all of them use the same rules. We want to start to learn rules. We understand the rules, we understand how it works. Then we are going to understand what happened or what is the problem with the patient. Other thing is emotions. Emotion is a source of information. Some people have problems only from emotions. Then we are going to have special techniques to treat emotions. Our treatment is just from the point of view of the neurology, not like the psychology. We have two kinds of problems in the body: software and hardware. PDTR is to treat software. We have a broken bone, of course, PDTR is not the best treatment for a broken bone. After the bone heals, now we need to treat the software. is the best analogy, software and hardware. But software in a computer is around 96 to 97 of the problems. In the body, it's the same. Most of the patients has software problems. Just few of them have hardware problems. You will see people who has a tennis elbow, back pain, headache, has a many software. Most of them come from software. We want to learn how to treat software. The information comes from different sources. I mentioned visual, auditory, receptor, etc. Most of the information, or most of the pathways, or most of, we need a lot of information to give the proper again, information to the brain to respond. Around 75% of the nerve carry information to the brain. Only 25% is efferentation, it's just motor or response. If we don't have information, we cannot move. The body cannot respond if we don't have information. Exist many different receptors. Mechano, chemo, nociceptors, we can say emotional receptors. And all of them has only 3 different ways of response. Only 3. Responses are 1, in brain. Means thinking process, mental process. Number 2, we have organs or organ response. Means more or less response from the organs. Means more enzymes, more acid, more or hormones, etc. And number 3 is inhibition or facilitation in the muscles. Could be skeletal muscles, could be muscles in the gut, could be muscles in the heart. These are the 3 different ways of response. Only. We have too many ways to give information, but only 3 different ways of response. Because it's so hard to test continually the organs, we want to use muscle testing. For example, we can put a probe, a sonda, we can put a sonda in the stomach, and we can measure how much acid the dogs can produce acid. But this takes a lot of time for the acid. It's not immediately, it takes a few seconds to produce acid, and we need to measure all the day. It's going to be very hard to measure how much acid we produce. And we measure only one thing, the stomach. How can I measure the insulin? How can I measure other organs? This is very hard. And muscle detection is so easy, but it's easier to test. We're going to learn how to test the muscles first, like in the books, Kendall and Kendall. Up After we start to learn Kenda and Kenda, we are going to start to learn some difference. For example, how need to think how to test kinematic change, how to test specific muscles that is not described properly in the books. To the beginning, we need to learn how to test Kenda and Kenda. Okay, what happened if we have an aberrant or bad information? We have bad information, we have a bad response. If I give a bad information to the brain is going to respond to this information, we have a bad information. The body normally needs to have some facilitation and inhibition. To bend the arm, I need to facilitate the biceps. I need to inhibit the triceps. And as soon as I want to start to have more flexion, I'm going to start again to facilitate the triceps. To do this one, I need information. If I have a bad information, probably I'm going to have inhibition of the biceps. When I try to lift something, I inhibit the biceps. And then I'm going to try to move the biceps with other muscles. Then we're going to overload small muscles, or we're going to have a problem in the elbow or in the shoulder just because they are not working properly. This is why we are going to have a lot of problems with the joints, or with the muscles, or with the bursas, or with the etc., just because we have bad information. This is, I'm going to tell you a special rule. This is the mini balls in the spin, in the receptor. 10, 0, 50, 100, 50, 100, 50, etc. It's the mini balls. It's the stimulus to the receptor. Receptors are just a transductor. Change the stimulus to electric information through the nerves. If I give more stimulus, I'm going to increase the signal. Receptor has another problem. They just transmit the signal. If I am normal, normally all neurons are going to fire 24/7. If the neurons are not firing, they are going to have a degeneration and die. We need to fire all the neurons all the time. The step is the same. We need to fire all the time. Because we fire all the time, we want to be here. Is the basal stimulus. Is the minimal stimulus all the time. This gives us the muscle tone. I am relaxed, but still I can feel some tone in the muscles. This is muscle tone. What happens if I increase the signal? The muscle becomes stronger. I make the signal, and in the receptor make a signal, and some associated muscle become stronger. If I continue in the signal, now over to here, now this is the threshold, now going to be weak. We are going to say weak, but it's not the proper way, it's the proper word. If I have the degenerative process in the brain, when I cut the nerve, the muscle becomes weak. If you have a nerve compression, then the muscle becomes weak. When we have a stimulus, we have a software only, stimulus, someone becomes weak, someone becomes strong, these are not the proper words. We need to say inhibition or facilitation. A proper stimulus, I have facilitation. More stimulus, I have inhibition. But we can use weak or strong just for, because it's more easy to understand. But the proper words are facilitation or inhibition. Not the stronger, not weaker, more facilitation, more inhibition. But it's okay if we use the other words, especially for the patients. Then, the stimulus, stronger, more stimulus, weaker. If I decrease the signal, less signal, now we have inhibition again. We have a weakness again. This is the first rule. Facilitation, more stimulus, inhibition. This is the same rule for all receptors. Okay? If we have a problem, how is this possible? What happened if we have a problem? The problem is not going to be in the receptor. The problem is going to be in a special nerves in the spine. In the spine, all this information comes to these neurons. Some stimulus, positive stimulus, negative stimulus, they put all of them together, and now they respond. These neurons are wide, dynamic,
wide dynamic range neurons.
Range neurons.
English, wide dynamic range neurons.
You can say these neurons in the spine receive all the information, and they are responsible for the sensitivity. We say we have a dysfunction of the Pacini. In reality, it's wrong. We don't have hypersensitivity, or we don't have dysfunction of the receptor. We have sensitivity or dysfunction in the wide dynamic range neuron. In the medical physiology books, they describe two different ways of stimulus. We can have temporal and we have the spatial. We can increase the stimulus in the neurons in two different ways, or both together. What does it mean? Okay, here we have the neuron. We talk about the spatial is because we have many sources of stimulus. One can be positive, one can be negative, the one can be positive, the one can be negative, for example. Then the neuron receives positive or negative, add the positive, subtract the negative, and then we have a result. This is how the neuron is going to respond. Temporal. Temporal means time. If I give stimulus to the neuron, the same stimulus, at the beginning we have a response. Later, stop the response because we exhaust the neuron. Then I can give many stimulus for a short period of time, I can give many stimulus for a long period of time. Now, let's go back to here. I can reach the weakness in two different ways. One, huge stimulus. Big stimulus, I can reach the threshold, and now I can heal. Other way, I can make a normal stimulus for more time, and then I'm going to produce inhibition. Example, if I touch my head, it's a stimulus. This stimulus, at the beginning, make my neck stronger, my flexor become stronger. If I keep touching very soft, after a few seconds, probably 40 seconds, maybe 1 minute, now they become weak. The flexor becomes weak because I make a more stimulus for more time, and now I'm going to exhaust the receptor, and now I'm going to do the weakness. Got it? All of this is the normal response. Okay? What is dysfunction? If I say dysfunction, software dysfunction, what is dysfunction? Dysfunction is when the wide dynamic range neurons are so sensitive. They are so sensitive, this stimulus is enough not to facilitate, it's enough to kill, because the threshold becomes lower. These neurons are sensitive. I'm not going to inhibit here. I'm going to inhibit here, or here, or here, or here. If I have a dysfunction, then maybe one stimulus, instead of making it stronger, make it weaker. If it is more, have more hypersensitivity, more dysfunction, maybe this basal basic stimulus or the neurons or the receptors is enough to produce the weakness. These rules, this understanding is going to help us to understand the detail. Okay, what happened here? Example, ligaments. The ligaments all the time has some tension. The ligament here has tension all the time. What happened if I push both ends together to do what? To decrease the tension in the ligaments. I'm going to decrease the signal, and now associated muscles become weak. But this is different because this is hyposignal. This is hypersignal, hyposignal. In both cases, we are weak. We need to learn how to differentiate the hyposignal from the hypersignal. This sounds simple, But we need to understand very clear this concept because it's going to be the basement, the foundation of the physical therapy. This is not in the physiology books. It's a new concept, it's a completely new concept. But this is what we want to understand what happened with the patient. Any questions now? The brain controls everything in the body. If I have reflux, if I have migraine, if I have colitis, if I have a weakness, if I have whatever, everything is under the rules of the brain. Then, now we need to take care of the neurology. Are you orthopedic surgeon? When we finish orthopedic surgery, or surgery is nice when it's needed, we abuse a lot of the surgery because we think in mechanics. We need to think in neurology because most of the patients has problems with software. We need to treat the information. We need to treat the signal. We need to treat the wide dynamic neurons to make them work properly. It's not about inflammation. I don't care about inflammation. Inflammation is a normal response. We have a trauma. We have somebody have a lack of oxygen, or you have a trauma, and we have an inflammation. I don't care about the inflammatory drugs. I need to fix the problem. If I fix the problem, inflammation disappears. Most of the doctors care about inflammation. Anti-inflammatory drugs, cortisone, etc., etc. Other is only exercises. If I put the patient to do exercises, but the brain is not using the muscles, I'm going to produce more problems. I need to fix first the problem, and then I can do exercise. I'm not against exercise. I love exercise. But we need first but we need first to fix the dysfunctions in the wide dynamic neurons. Remember, we have many chemoreceptors. Mechanoreceptors, nociceptors, and chemoreceptors. Noci means injury. Anything that produces injury is a nociceptor. Could be cold receptors, could be hot receptors, could be traumatic receptor, could be just rubbing, this is nociceptor. We will see this specific receptor through touch is a terrible receptor when it is functional. And we have a proprioception, interoception, and interoception. Interoception is everything that we feel inside of our bodies. Interoception is everything we can feel in the environment. In proprioception, we have two kinds of proprioception, conscious and unconscious. It's important, all of these details are going to be very important in the specific topics. As I said before, the brain receives 75% of information and gives 25% of efferentation. We need a lot of information, much more. We use much more of the neurons, or the pathways, than for the motor system. Muscle testing. Why or what are we testing? This is the first important topic. 25 years ago, I became an international teacher of applied kinesiology. I was working in the UK. I was member of the examinators. I was very involved in AK. For me, AK was nice because give me foundation. But they have many mistakes, similar to other techniques. The first mistake, they don't know what they are testing. Many different systems that use muscle testing, they have a research for muscle testing. They said we are testing the muscle, and they use machines to measure how much weight they need to put for the muscle. I want to put the machine here. Oh, I need 3 kilograms to be the patient. Now, after the diffusion, I need only 1 kilogram. This is wrong. It's not usable. Why? Because we are not testing strong. We are not in how strong is the muscle. We are testing a reflex. What are we testing? We are testing the myotactic reflex. This is what we are testing. Myotactic PH.
No TH. No TH.
What PH? Yes. What PH? No. Myotactic reflex. This is what we are testing now. When we test the patient, we test myotactic. So that's why it's inhibition and facilitation. What is myotactic reflex? Who knows what is myotactic reflex? This is from medical books. This is from physiology books. What is the myotactic reflex? In the books, it have only made a small paragraph about this one. They mention that I have a muscle, and I put some pressure or weight. The reflex lock the muscle. When we put the pressure, we lock the muscle. When we remove the weight, now we unlock the muscle. That's why we need to test locking. We lock the muscle or not. We are not testing how strong is it. Can we lock it or not? This is the myotactic reflex. And the first and most common mistake when we test the muscles is when we facilitate, then inhibit the reflex, and then inhibit the reflex. Example, I want to test here. Release a little bit and push again. Now it's going to test weak. If I push, release a little bit and push again, now it is weak. I have seen this everywhere, this mistake. What happened here? Push, lock the myotactic reflex, release a little bit. Now I remove the myotactic reflex, and now push again, and the brain is not able to enable this so fast. We need to give little more time for the brain to enable again the myotactic reflex. If I test, if I test the muscle, push hard, this is strong. Yes? You want to push again? Slowly push again. Again lock, release. Yes? If I push and do
¿Esto lo diferencia?
I want to push, remove a little bit, and push again. Push, and now this is going to be weak. It's the biggest, most common mistake.
Esta es el error más grande.
The most common mistake is this one. We enable, disable, and then again fast test again, and the brain is not able to enable again the qualitative reference. Then we need to give time. Test, push, 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 slowly, give time the brain to enable this one. You remove the hands or decrease the pressure. Again, push again, push again. Slowly. We need to help the patient to do it. If he can do it, he can do it. If he cannot do it, doesn't matter if we give time, he's going to test weak or we have an inhibition of the muscle. This is the most common mistake we do consciously or unconsciously in our patients. Why we know that? Because it's a reflex. And I have seen in all the systems, I can tell you about AK, many people made a mistake all the time. They have no idea, but they made the same mistake all the time. If they do this one, of course, they are going to get it from day one. They don't get it from the patient, they get it from day one. I want this to be dysfunctional, but it's weak. I want this to be stronger, now it's strong. Well, this is the first mistake. Okay, let's start with the receptors. We're going to start with the more, I believe years ago, were the most simple receptor. Now I believe it's not the most simple, it's one of the more harder or difficult receptors. The spindle cell in the muscles. We're going to start with the spindle in the skeletal muscles. Many years ago, I am talking about 20 years ago, or 10 or 15 years ago, still this was the concept. We're supposed to have two kinds of receptors, back and chain. Back and chain are the receptors in the spindle. On both sides, we have a muscle, a very small muscle. This is a muscle. The muscles are just to keep the receptor under tension. We need tension in the receptor to fire. And we believe that every spindle has one back and one chain at that moment. Now we know it's different. Now we know that the spindle has too many backs and too many chains. The chains, all of them are the same. We have around 11, between 8 and 11 chains. Of course, intrafusal muscle on both sides. The normal muscle is named extrafusal. This one is the intrafusal. Then we have many chains and we have many backs. Around 5 and 3 or 5 and 4. But we have two different kinds of backs. We have one back named dynamic, other back named static.
Can I ask something?
Yes.
Regarding the anatomy of the spindle cell, because I tried to research this yesterday and I couldn't find much. Regarding the anatomy, at the end of those receptor cells, is there like more muscle fiber with actin and myosin, or is it connected directly to the tension? What is
It is inside of a small capsule. Is it not graphic?
And the ends of
has
the,
attachment to the fibrous tissue or to the fascia, whatever, and this has inside of the muscle.
okay, so
If
they are not
you
connected,
increase the size of the extrafusal muscle, you're going to stretch the spindle. That's why you need the muscles, interfusal muscles, to adapt to the change of the muscle. Then we stretch the fusel, we need to give more room to stretch this one.
so they are not directly connected to actin and myosin proteins, they are just within the fascicle and the fascia.
It's considered by fascia.
Okay, got it. Thank you.
Okay. We have two different kind of bags. Why we do different kind of bags? Because one of them is more associated with the isometric and the other two to the isotonic. Let me explain it. Okay. To understand this one, we need to first to understand the innervation of the spindle. We can see here two different kind of nerves. What it means 2 and 2A? Is the name of the nerve? No, it's the size of the nerve. It's the size of the nerve. Then we have many nerves. First one, the nerve that are the innervate the receptors. 2 and 2A. To understand 2 and 2A, we need to go to the chart. This is the chart of the size of the nerves. Diameter, speed, conduction speed. 2 micrometers, 15, 10, 5, etc. And this is bigger, is fastest. In this part, in this chart until here, they are faster because they are myelinated nerves. And these part are non-myelinated nerves. Then we can use two classifications. The general classification is A, B, and C. A alpha, A beta, A gamma, and A delta. These can be used for sensory or motor nerves. And this C. What is B? Supposed to be B, the size of the nerve of the sympathetic and parasympathetic system. Now what? This is C. Other classification, sensory, only sensory. We have 1, 2, 3, and 4. 1A and 1B, or 2, 3, and 4. Here, in this case, in the spindle, they use the sensory classification. Then we have 1A and number 2. One is the fastest of all the nerves, the one is very fast but not the fastest. Here we have the spindle. Primary ending is 1A, secondary ending is number 2. Got it? Any questions till now? Okay, let's go back to the spindle. 1A innervates all the bars and all the chains. Number 2 is very fast, but not as fast as 1A. Innervate all the chains, but only the statics. What is the purpose? Remember that in the spindle we are going to measure 3 different things. Stretching. 2 kinds of stretches, isometric and isotonic. and speed. Stretching and the speed of the stretching. This is what we need to measure in the spindle cell. In this case, when we innervate all of them, including the dynamic, is when we are going to test the isotonic. Isotonic means we have the same tension, but we change the length of the muscle. Then I'm going to stretch the muscle. This is the isotonic. If we stretch the muscle and contract and make it shorter the muscle, is isotonic too. What are isotonic? Isotonic eccentric and isotonic concentric. Here is where we need more to measure the speed. In the other one, in the nerve 2, the first one was 1A, this one is number 2. We are going to measure only the isometric. It means we're going to increase the tension, the contraction, but without changing the length of the muscle. In AK and in other techniques like cryopsychotherapy, some osteopaths, they have a mistake. When they stretch the muscle and become weak, they say there is a myofascial problem. This is not a myofascial problem. This is spindle. This is isotonic problem in the spindle. If I stretch only the fascia, maybe I can produce inhibition because we have a dysfunction in the Golgis in the fascia. But if we are going to do this one, it's going to be isotonic, concentric or eccentric. We want to see how to differentiate each one. We have tools to differentiate everything. Then this is the innervation of the spindle in the nucleus, in the receptor. Back dynamic, back static, and chains. Got it? Okay, there are more. Exists innervation of the diffusor muscle. Exists innervation of the intrafusor muscle. This is sensory. All the other are after the effort. I found this one. It's brand new, that's why we have some mistake here in this drawing, because this one, number 1A and number 2 has a different innervation. The ring range is the other one, but in this we are able to see the other nerves. We have alpha motor neuron, beta motor neuron, and gamma motor neuron. Alpha motor neuron innervate the external extrafusal muscle. Is the fastest motor nerve. Alpha motor neuron. Beta innervate this one, the extrafusal, and at the same time innervate the intrafusal. Both of them. It is not perfect, this drawing, it's both of them. And gamma innervates all interfusion. This author, he believes that the interfusions are innervated by different ways. The other one say that all interfusions are innervated by beta and gamma. This one, he suggests that the gamma is only the interfusion B2 and chain, and the beta B1 and extrafusion. Still, I need to look for more research to see if it is the real innervation. The other author said alpha only extrafusion, beta both, and gamma both. But well, this one believes that we have an innervation only some part of the intrafusion. If this were real, then we need to find more options to test the spindle dysfunction. But well, this is the sensory, this is the motor nerve. Why we need to keep innervated the intrafusion? Because we need to keep under tension all the time the intrafusal muscles. If these nerves are not innervated properly, the intrafusion becomes weak. If this becomes weak, then we have no more tension in the back and chain, and now the muscle becomes weak. Got it? Okay. Okay, here is the same, but more or less is using the proper medical words. Here I contract the muscle, the extrafusion muscle. I need to contract or to adapt with the spindle. We have a shorten of the extrafusion, we need to shorten the intrafusal. This is named dynamic of spacing response. This is primary ending, the fastest. This is secondary ending, the nerve number 2. Here again is right because it's innervates all the receptor. This one innervates all of them except the dynamic. This is for isotonic. This is for isometric. This author said gamma innervates all of them except the dynamic and the bed and the, well, in both cases, gamma. Every book has different things. This says gamma for this one and gamma for this one. The other author says gamma is only for some of them and beta is for the others. Every book has a completely different interpretation or different understanding of the anatomy. Still, I need to look for new paper to see which one is right. But what is right is we have gamma, we have 2 different bags, all of them, we have many chains, and all of them need to be under tension by the interfusion. Okay, let's go now to see how can we deal with the spindle. The spindle is not as simple as we understand. But the spindle is simple because the compensation is so simple. It's only isometric compensate with isotonic. We're going to see that now. Okay. The concept of compensation is not new. But mentioned, they say we compensate how mechanically. I have more pressure on this leg, then I compensate with the shoulder. I compensate with the head with the opposite side. By video compensation, we talk about the second. The brain, we have a dysfunction. I'm going to mention dysfunction of the specific receptor. But remember, it's not a receptor, it's the spinal cord and quite dynamic nerve. But it's easier to talk when I say receptor. If I have a receptor dysfunction, the brain compensates with another dysfunction. The brain creates another dysfunction to compensate the first one. For this one, we are going to start now to measure the primary. I have a dysfunction. We ought to learn later how we can produce the dysfunction. I have a dysfunction. Isometric. Isometric is dysfunctional. Now I'm going to mention this one is primary. If you have a primary isometric dysfunction, the body produces dysfunction in another muscle, in another spindle. I'm going to name it secondary. How can I know that I have a dysfunction isometric? I have a strong muscle. But if I contract the muscles 3 seconds or more, become weak. Wait 3 seconds, become strong again. Again, test, strong. 3 seconds, test again, weaken. The first contraction is strong. Then release 1 second, test again, and now weaken. This is the isometric dysfunction. If this is the primary, the original one, we are going to have a secondary. Who is the secondary? Secondary, in this case, in the spindle, is going to be isotonic. If the primary is isotonic, the secondary is going to be isometric. That's why I start with the spindle, because we have only one option of this function. Isometric, isotonic, isotonic with isometric. How can we test the isotonic? It's a strong muscle. If I stretch it, become weak. Primary and secondary are muscles that are antagonists. Then, if I found a muscle that becomes weak after stretching, an antagonist for sure is going to be the opposite. It is isotonic, the other one is going to be isometric. Isometric, the other one is going to be isotonic. The main problem is to find them. We need to learn to see them. We want to give you every day more tools. We want to be easier after many tools. But we need to learn from scratch. We need to learn how to see them. We need to learn how to test them. We need to learn to use all the tools, not only one of them because it's not complete. It's easier you can handle and use all the different tools. This vector is medio clavícula. This test is strong. Yeah? Hold. 1, 2, 3. Hold strong. And now, hold. And now, this weaken. Hold strong. And now, this weaken. Why weaken? Why become weak? It's supposed to be strong all the time. Let me tell you the other one. Maybe the other one is normal, straight. Remember to full rotation of the arm. If not, he start to use the biceps. Then, hold. 1, 2, 3, 4. Relax. And 1, 2, 3, 4. And all the time is strong. This is normal. This is not. Here we have a problem with the spindle. Which spindle? We have a lot of spindles, thousands and thousands. One of them is enough to inhibit. We have one dysfunctional spindle, or well, one spindle associated with dysfunction in the spinal cord is dysfunction, and now the muscle becomes weak. Next again, let me show again. What's wrong? 1, 2, 3. This again. Now, this is weak. Yeah? This is primary or secondary? I have no idea. Now, I know we have a dysfunction. I need to find antagonist that has the opposite. It is isometric, the other one is going to be isotonic. Who is the antagonist of the pectoralis? Could be abdominal oblique on the opposite side. Could be overtrap. Could be rhomboid. Could be, we have many options of antagonists. What do you think? Is this isometric? We need to test isotonic. Let me tell you upper trap. This is strong. Relax. Stretch it up. And this is weak. Upper trap is a very, very strong muscle. If he is strong, I cannot beat him. If I test another one, stretch this one, test again, so up, and this is a rock. Then, this one weaken if I stretch it, but it's strong if I contract a few seconds. 1, 2, 3, test again. It's still strong, even stronger. This one, if I stretch it, test again, it's strong. This inhibit only with isometric, this is only with isotonic. Maybe they are the pair, primary and secondary, maybe not. They are the pair. Can be this dysfunction against the other one, okay, this dysfunction against the other muscle, and this can be dysfunctional against another one. Can be different pairs, but probably it's going to be paired. We need to learn more tools to find them. How can I know if they are paired? How can I know if they are primary and secondary? how can I know which one is primary? We have many questions to answer. In PTR, 99 of the time you spend in the patient is for diagnosis. 1% is for treatment. This means very fast, and it seems if you know have a proper diagnosis.
Can you say it one more time? 99% is.
Sorry?
99% is
All the time is for diagnosis.
diagnosis.
As soon as I know diagnosis, the treatment takes 5 seconds to treatment. Okay, how can I know which one is primary? Okay, this is the easiest part. If I esteem the primary weakens, yes? But if I esteem the primary weakens, secondary weakens too. This is the helper, this is the boss. If I have more work for the primary, I have more work for the secondary. More stimulus to the primary, weaken, then weaken. If I esteem the secondary, this weakens, but the primary is stronger. Means more primary is equal to more secondary. It is signal. So more weakness, more weakness. More secondary, stimulus secondary, equal less primary. Then, thank you very much. Good job. Good job. Okay. If I esteem the pectoralis, isometric 3 seconds or more, upper temporal whole week. These tell me many things. One, they are associated. Second, pectoralis is going to be the primary and it's going to be the secondary. If I esteem the upper trap and this one weaken, proper esteem, weaken, and better keep it strong, it means it's secondary.
Can you repeat, please?
More primary, more stimulus to the primary, increase the stimulus in the secondary, increase the signal of the secondary. And then it's going to be weak, it's going to be weak. More steam to the secondary, this weakens, but this one will produce more compensation to the primary, and primary become strong or keep strong.
Facilitating.
Sorry?
Stays facilitating. When you mean strong and weak, that's the thing.
Come here. Let me show you.
Can we record this part of the demo?
Now I don't know which one is primary. I'm going to test. If I stretch this one, this weakens. Yes? If I stretch this one, there's the pectoralis, and keep it strong. Yes? Means secondary, or maybe they are not pairing. Got it? Now, I'm going to test the prime, this one. 1, 2, 3, again, and this weakens. Now, there's this one, and this weakens. Got it? This one, stimulus here, proper stimulus. Which one is the proper stimulus? Isometric in this case. Inhibit the pectoralis and inhibit the secondary. If I stimulate the secondary, proper stimulus is stretching. Because it's isotonic. This one inhibits, but this one keeps it stronger or becomes stronger. You got it? Questions?
Yeah, I got one question. So if you apply a stimulus on the compensation,
Yes.
that means
More compensation.
more compensation.
I am weak, but the primary weak is stronger.
Yeah. So if the primary is stronger, which is the main in this function, isn't it?
Yes.
The primary is the main in this function, and the secondary is the compensation, isn't it?
If you have dysfunction primary, dysfunction secondary.
Yeah. But when you weaken the compensation, the primary becomes
Stronger.
stronger.
It's stronger.
Okay.
Yeah. More primary, this is the boss, this is the helper. You have more work, the helper needs to work harder.
Yeah.
If the helper work harder, now the boss need to work less.
Yeah.
Okay?
That's it.
Yes.
And there's no rule for the primary dysfunction, it has always to be isometric.
They are 100 rules. You have a lot of rules, but we want to walk slowly.
I guess the question was, in his case, you were mentioning the primary dysfunction, which is probably the pectoralis, it was isometric.
In this case, it was primary and it was secondary. It could be different. Could be secondary, could be primary. Could be primary here and secondary there. That's why you need to test.
But it being an isometric or isotonic, that does not correlate to being primary or secondary. It can be
No. It means I can be primary isometric, can be primary isotonic. We're going to learn later that can be the opposite. Isometric is stretching, but can be it's shortening, but it's not so common. This is the common. Shortening can be the dysfunction. It's a strong muscle. If I push together the biceps, weaken, but it's not common. That's why I'm focused more on straight leg or isotonic eccentric. Okay, let's see more details. These can be in any muscle. Could be between the masseter and can be the masseter and external pterygoid. Can be between SCM and against the psoas. Can be SCM against the external oblique. Can be normally antagonist. It's an internal rotator, could be external rotator or internal on the opposite side. Can be abductor with another with adductor. Can be with an extensor. Now, they are antagonists. This helps us to have an idea of where can we find the pairing. But this is simple because in spin we have not only two options. The isometric, the one is isotonic. The isotonic, the one is isometric. That's why it's so simple. Can you help me? To test the SEM, we need to have the neck in extension, straight. Because if I move the neck into an extension, became an extensor. To test this one like a flexor, we need to have the neck in straight position. What's wrong? Is it weak in the clear? It's worse. You are strong in the clear. It becomes weak if I proper stim. But this SEM is weak in the clear. It means that the sensitivity in this wide dynamic range of neurons is so strong. Means that the threshold is here. Means that only the minimal basal firing of the neuron is enough to Got it? Could be many things. Could be spindle, could be Golgies, could be anything. Could be organs, could be a lot of things. I'm going to give you one tool more. If I rub the receptor and it's mechanoreceptor, rubbing decreases the stiffness of the mechanoreceptor. Rubbing decreases the stiffness of the mechanoreceptor. Rubbing is an nociceptor. But now we're going to test it. I want to see if the receptor is here. I'm going to rub the SCM here and test. How strong? Now it's strong. It means two things. One is mechanical. Second one is here the receptor. Got it? Probably can be Golgi, can be spindle. How can I know it's a spindle or not? I'm going to give you another rule. The rule is this is not this is a isometric, isotonic. For example, this is weak, isometric. If I steam isotonic, give the stimulus of the opposite, become stronger. If this is weak, and then give the stimulus of the opposite, become stronger. Then let's see if I stretch the SCM, also become strong. What is this? Isometric, because isotonic helps. Now I know that this one is isometric because isotonic stimulus helps. Got it?
One more time.
One more time. Isometric. This is weak in the clear. If I rub, become strong. It's mechanical. Could be spindle, could be many things. So well, one of them it could be spindle. If I do the proper stimulus to the muscle of the opposite dysfunction, become stronger. Means it is isometric, isotonic helps. Then stretch it. This again is strong. Because isotonic helps, then this is isometric dysfunction. Got it? Okay, now isometric. I need to find another one that probably could be weak in the clear. And it's going to be isotonic. SCM is a muscle, but who is going to be the antagonist? Who is in terms of the SCM? Number one, the opposite one. Right? The left. Who else? Pectoralis. Who else? Abdominals. Who else? Extensors. SCM is a flexor, rotator, and lateral flexion. Could be psoas on the opposite side. Yeah? SCM here is weak. Let me test. The middle. Hold. 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 It's not so strong. This one. Hold. Please. What's wrong? Both are weak. If I roof this one is going to be stronger. If I improve the primary, improve the secondary. Yes? I don't know if this is associated with this one. I don't know. I don't know if this is primary. I don't know. Let me try. I'm going to test again. Roof the SEM. Now it's a rock. Now this becomes stronger. You're roofing here. Now this is stronger. It means this is primary, this is secondary. But this what do we do? If I roof here, it doesn't help. It means this is primary, this is secondary, and this is different dysfunction. Well, how can I make this one stronger without roofing? Now, you saw us, but is it strong? Why is it strong? Because I am doing the opposite test stimulus to the SEM. Opposite is isotonic. If I stretch it, this improves the primary and then improves the secondary. Less dysfunction here, less dysfunction here. Then stretching the neck made this one stronger. Got it? Now, I want to do the opposite. What can I do to improve the neck? How can I improve the SEM? This one is weak in the clear. Weak? Very, very weak. How can I improve this one?
With the psoas.
I can rule the psoas, but in this case it's impossible because it's so deep. What can I do here?
Stretch the psoas.
Why is stretching?
Because it's the isotonic.
Isotonic. You stretch the psoas, you increase the signal here. If I increase the signal here, I'm going to prove this one. You are right. Here, I do the opposite because I need to decrease the primary. Less primary, less secondary. But if I want to improve the primary, I need to increase the secondary. More secondary, less primary. Less primary, less secondary. Right? That's why here I do the opposite. Here I do the proper stimulus. Then I do this one, raise the neck, and this is strong. You see how easy it is? Easy. Any questions in now?
Lunchtime already.
Sorry?
It's lunchtime already.
Lunchtime as well. It's only half an hour, just but it's for pastel, not for lunch. Okay? You want to try? Okay. He told me this is the best room we have in the history. I want to see that. Okay. Practice, find muscles.